Hello and welcome to the Functional Neuroanatomy course. Today we will talk about the motor pathways. We are first going to talk about how movement is generated. We will then move on to the different components of the motor system and the different pathways these circuits take, as well as their vascular supply. Lastly, we will consolidate everything learned in this module through clinical cases. By the end of the course, you should be able to know how a simple voluntary movement is generated and what a dysfunction along the pathways responsible for this movement looks like in a patient. Voluntary movement is a result of a muscle contraction happening at the command of a corresponding motor neuron or unit. The motor neuron is the final common pathway. It receives inputs from multiple cortical as well as subcortical structures, which all converge at the motor unit. The initial signal comes from the motor areas of the cortex located anterior to the central sulcus. It travels down the corticospinal tracts to reach the motor neuron. These motor areas include the primary motor cortex located immediately anterior to the central sulcus, in the posterior frontal lobe, followed more anteriorly by the premotor cortex and the supplementary motor area. Animal experiments show that the primary motor cortex is responsible for execution, whereas the premotor and supplementary motor areas are responsible for higher level planning of the movement. In essence, before starting a movement, the thought of initiating a movement lights up the supplementary motor area. The correct sequence of movements is then chosen by the premotor cortex, which then gives the command to the primary motor cortex to execute. Of course, all of this takes place in a matter of milliseconds, so you are not aware of it. The primary motor cortex is organized in a highly topographic fashion, with each area in the cortex representing a different area of the body, as seen in the famous homunculus representation. As opposed to common belief, however, what is represented in the primary motor cortex is sequences of movements rather than individual muscles of the represented parts. The motor fibers of the corticospinal tracts arise from the primary motor cortex. These tracts then travel through the corona radiata and internal capsule, still maintaining that topographic organization represented along the cortex, the brainstem, and the spinal cord. They pass through the pyramids of the medulla, hence the name pyramidal tracts, cross the midline or decussate, and descend in the lateral column of the spinal cord. A small percentage of the pyramidal tracts do not cross but descend in the anterior column of the spinal cord and control axial muscles such as trunk and proximal limbs, thus helping maintain an upright stance and gross position of the limbs. The corticobulbar, also called the corticonuclear fibers, originate in the same frontal motor cortex area, but mainly from the area where the face is represented along the homunculus. They pass through the corona radiata and posterior limb of the internal capsule, terminate in their target nuclei in the brainstem. They are called corticobulbar because they terminate in the bulb, which is the old terminology for the brainstem. The corticobulbar motor pathways are responsible for the innervation of the muscles of facial expression, articulation of speech, mastication, as well as swallowing. Let's take, for instance, the muscles of facial expression. The same muscles are also responsible for proper articulation of speech, which is why patients with facial weakness are also usually dysarthric. These muscles are innervated through the seventh cranial nerve. Their corresponding corticobulbar tracts terminate in the pons on the dorsal and ventral aspects of the seventh cranial nucleus. The ventral aspect is responsible for the innervation of the lower part of the face and receives unilateral input from the contralateral corticobulbar tracts, whereas the dorsal aspect is responsible for the innervation of the upper part of the face and receives bilateral input from the corticobulbar tracts. This explains why a central lesion in the brain along the pathway of the corticobulbar tracts causes weakness of the lower face only, whereas a lesion affecting the entire nucleus of cranial nerve 7 or the nerve itself causes both upper and lower face weakness. In addition to the corticospinal pathways, movement is finely regulated through subcortical pathways and loops. For the purposes of this course, we will focus on the subcortical descending pathways originating in the red nucleus and the tectum, the reticular formation, and the vestibular nuclei of the brainstem. The rubrospinal tract arises from the red nucleus, which receives input from the deep cerebellar nuclei through the superior cerebellar peduncle, as well as the motor cortex bilaterally. Axons descend from the red nucleus in the crossed rubrospinal tract that descends in the lateral column, and then synapse on the interneurons in the spinal cord. Animal experiments suggest that the rubrospinal and corticospinal systems cooperate to control hand-finger movements. The rubrospinal tract plays an important role in control of flexor muscle tone. The vestibulospinal tract arises in the vestibular nuclei located in the floor of the fourth ventricle. The nuclei receive input from the vestibular nerves and cerebellum. The vestibulospinal tract arises mainly from the lateral and medial vestibular nucleus and contain both crossed and uncrossed fibers that project to the anterior horn neurons in the spinal cord. This tract plays an important role in maintaining an erect posture. So, to summarize so far, movement starts in the cortical areas, motor planning in the premotor cortex and supplementary motor area, and movement generation in the motor cortex through the corticospinal and corticobulbar tracts. These main tracts interact and are regulated through small subcortical pathways such as the rubrospinal and the vestibulospinal tracts. In addition to movement planning and generation, movement is also finely modulated through two main big loops, the cerebellar loop and the basal ganglia loop. Let's start with the cerebellar loop. The cerebellum, which means small brain in Latin, represents 10% of the volume of the brain, although it contains 80% of the neurons present in the brain. It consists of two hemispheres separated by a midline structure called the vermis. The surface of the cerebellum shows multiple folds called folia. It contains 3 pairs of midline nuclei, which are the only output from the cerebellum. Just like the brain, the cerebellum has a somatotopic representation of the body. It is traditionally thought of as a motor coordination structure, although recent studies show involvement in cognition as well. That is beyond the scope of this lecture. From a functional anatomy standpoint, the cerebellum can be divided into 3 areas. The vestibulocerebellum, also known as the flocculonodular lobe, controls the axial muscles involved in balance and coordination of eye, body, and head movements. Information from the vestibular apparatus travels along cranial nerve 8 to the vestibular nuclei in the medulla, directly entering into the vestibulocerebellum. Information leaving the flocculonodular lobe projects to the vestibular nuclei, acting as deep cerebellar nuclei. Information then descends on the medial and lateral vestibulospinal tracts, controlling posture. Dysfunction in this region, or the vestibulocerebellum, results in ataxic, wide-based gait, which is characterized by unsteady, uncoordinated walking. Other dysfunctions include postural sway and nystagmus. That was number 1, vestibulocerebellum. Number 2, the spinocerebellum, is in the central portions of the anterior and posterior lobes and is located in the vermis and intermediate zones. The main function is the ongoing regulation of movement via error detection. Comparing the intended action with what is actually occurring, the spinocerebellum integrates information from the motor cortex with sensory feedback. The spinocerebellum modulates muscle tone. Somatosensory input enters the spinocerebellum through the spinocerebellar pathways, bringing proprioceptive and cutaneous information. Somatosensory inputs from the trunk and the head enter the vermis, whereas somatosensory information from the extremities go to intermediate zones. Output from the vermis exit through the fastigial nuclei descending to the brainstem and lateral vestibular nuclei. It also ascends to the thalamus and primary motor cortex. Outputs from the intermediate zone project to the interposed nuclei. Axons descend through the red nucleus to the rubrospinal tract. Ascending projections go to the thalamus and the primary and supplementary motor cortex. The spinocerebellum is somatotopically organized by functional activities such as the hand is located near the mouth. The axial muscles are located in the vermal region and the limbs in the intermediate regions. Dysfunction in this region of the brain results in hypotonia. The cerebrocerebellum is comprised of the lateral zones of the cerebellar hemispheres. The functions include preparation of intended movement, planning and timing of voluntary movements, as well as learned and skill movements. Information from cortical areas are sent to the cerebrocerebellum through the pontocerebellar pathways, which synapse in pontine nuclei in the brainstem. Outputs project through the dentate nuclei to the thalamus, continuing to the motor, premotor, and prefrontal cortices. This information then descends in the corticospinal and reticulospinal tracts. Putting it all together, the cerebellum and cerebral cortex, or corticospinal tracts, are in a constant feedback loop through multiple pathways, all related through the thalamus. The cerebellum is hence involved in fine-tuning and coordination of movement rather than initiation of movement. It acts as a comparator. It monitors the intention of the movement and the actual movement performed. It then compares those command signals with the sensory information generated by that movement and sends out corrective feedback. Because of that, cerebellar lesions cause uncoordinated ataxic movements rather than weakness or paralysis. That was the cerebellar loop. Now let's talk about the basal ganglia loop. The basal ganglia are a set of subcortical gray matter structures developmentally older than the corticospinal system, which includes the corpus striatum, which includes the caudate and the putamen, the globus pallidus, the subthalamic nucleus, the substantia nigra, as well as the red nucleus and reticular formation in the brainstem. This animation shows coronal as well as axial cuts through the model to better correlate the 3D anatomical model with brain MRIs you see in daily practice. The function of the basal ganglia in motor control is not understood in detail. However, the basal ganglia seem to be involved in the enabling of practiced motor acts and in modulating motor programs stored in the motor cortex and some subcortical motor structures. Voluntary movements are not initiated in the basal ganglia. They are initiated in the cortex. However, proper functioning of the basal ganglia appears to be necessary in order for the motor cortex to relay the appropriate motor commands to the lower levels of the hierarchy, such as brainstem and spinal cord. The striatum is the major site of input to the basal ganglia, whereas the globus pallidus is the major site of outflow. Different feedback loops exist within this system, the details of which are beyond the scope of this course. The striatum receives input from the motor cortex, the premotor cortex, and the frontal eye fields. These cortical projections, called the corticostriate projections, are excitatory. It also receives input from the intralaminar thalamic nuclei, as well as the substantia nigra and brainstem through the striatonigral pathways. These pathways are what's involved in Parkinson's disease, for example. Two distinct pathways process signals within and between the basal ganglia and the cortex, the direct pathway and the indirect pathway. These two pathways have opposite net effects on thalamic and hence cortical targets, like the yin and yang, if you will. Excitation of the direct pathway has the net effect of exciting the motor cortex, whereas excitation of the indirect pathway has the net effect of inhibiting output from the motor cortex. The normal functioning of the basal ganglia involves a proper balance between the activities of these two pathways. The direct pathway involves input from the cortex to the striatum, which then sends inputs to the globus pallidus interna, which projects to the thalamus and back to the cortex. The end result of this pathway is excitatory, shown here in green. The indirect pathway involves input from the cortex to a different set of cells in the striatum, which projects to the globus pallidus externa, which in turn projects to the subthalamic nucleus, then back to the globus pallidus interna, thalamus, and back to the cortex. The end result of this pathway is inhibitory, as shown in red here. An important pathway in the modulation of the direct and indirect pathways is the dopaminergic nigrostriatal projection from the substantia nigra pars compacta to the striatum. The nigrostriatal pathway has the dual effect of exciting the direct pathway while simultaneously inhibiting the indirect pathway. Because of this dual effect, excitation of the nigrostriatal pathway has the net effect of exciting the cortex by two routes, exciting the direct pathway, which itself has a net excitatory effect, and inhibiting the indirect pathway, thereby disinhibiting the net inhibitory effect of the indirect pathway on the cortex. The loss of these dopamine neurons in Parkinson's disease causes the nigrostriatal pathway to have less of an effect, which then tips the balance in favor of the indirect pathway with a subsequent pathological global inhibition of motor cortex areas. These pathways have been the target of Parkinson's disease treatment, historically involving lesioning of the pathways through pallidotomy or thalamotomy to interrupt the indirect pathway at the globus pallidus interna or thalamus, respectively. This results in less inhibition. In the 1970s, this type of surgery was largely replaced by deep brain stimulation, or DBS, which allows for a more targeted and controlled action of the pathway involved. This video shows the effect of deep brain stimulation when turned on and off.
Okay, can I have you tap your right hand? Left hand? There you go. Turn. One more time. Turn. Back. Turn.
One more shot.
Back. One more time.
Was that? Yeah, I got both sides.
Oh, he did. He got both sides.
Okay, back.
Both sides. Crawl across.
Oh, you need to come over?
Got my right side. I've got my left side.
I just wanted to wrap this one back up since I had you so high.
She's almost there. Feel better?
Oh, yeah.
We have come to the end of our motor pathways. To resume, movement is the result of a muscle contraction, which itself is the result of the firing of a motor neuron unit. The signal starts in the cortical areas, namely primary motor cortex, premotor cortex, and supplementary motor area, and descends through the corticospinal and corticobulbar tracts to the target nerve. These tracts are modulated through subcortical descending tracts, as well as the basal ganglia and cerebellar pathways. These loops all act in concert to produce the smooth, perfect, goal-oriented movement we take for granted in our daily lives. Movement is organized in an increasingly complex and hierarchical, but also very efficient manner. Stereotypic repetitive movements, such as walking, are generated in neural networks including the brainstem, the cerebellum, and the spinal cord in a highly automatic fashion through what's called central pattern generators. These are local circuits of neurons that can trigger simple, repetitive motor activities without burdening the higher cortical functions. Specific goal-directed movements, however, are initiated at the level of the cerebral cortex. With repetition, these movements, such as playing a musical instrument or writing, can become automatic and taken over by lower brain centers. This is what happens with practicing and how practice makes perfect. So far, we have discussed the motor system components and pathways. Let's talk about the vascular supply of these structures. The brain is vascularized by four main trunks: 2 carotid arteries and 2 vertebral arteries. The carotid arteries form the anterior circulation, which supplies the anterior part of the brain, whereas the vertebral arteries form the posterior circulation, which supplies the posterior and inferior part of the brain. These two systems are interconnected by anterior and posterior communicating arteries in the circle of Willis. Inferiorly, the vertebral arteries form a single midline vessel, the basilar artery, after passing through the foramen magnum. The basilar artery terminates in the interpeduncular cistern, where it bifurcates into the left and right posterior cerebral arteries. In the brainstem, the blood supply of the motor pathways is supplied by the posterior circulation via paramedian branches of the basilar artery and the vertebral arteries. This time of flight MRA of the head shows over here the anterior circulation with both carotid arteries, which then bifurcate into MCAs, middle cerebral arteries, and ACAs, anterior cerebral arteries. On the right, you can see the posterior circulation with its two vertebral arteries, the basilar artery and the posterior cerebral arteries added on to form the circle of Willis. By comparing the territories irrigated by the vascular arteries discussed on one hand and the homunculus on the other hand, you will be able to predict the deficits caused by a stroke affecting the territories irrigated by each of the arteries, as we will discuss in the cases that follow. What happens when these systems don't work properly? We will consider different clinical scenarios in the following section of this module. Let's start with this first case. A 65-year-old African-American man with history of uncontrolled diabetes, hypertension, and smoking presents with right arm and leg weakness. What questions should you ask? So things you should think of are neighboring signs and symptoms, associated cortical signs or associated brainstem signs, associated spinal cord signs, and what's also very important is the onset of symptoms. Was it gradual or acute? So he denies any problems with his speech when asked about it. However, throughout the encounter, you notice that he says 10 instead of pen, and he pauses every now and then to look for the right word. The symptoms onset was acute. Neurological examination shows that he's alert and oriented ×3. His speech is mainly fluent upon initial encounter. However, when you start testing naming, he's able to name a key in a glove, but he's not able to name a cactus in a hammock on the NIH stroke scale. He's able to repeat common sentences. He is able to read and write. His cranial nerves are grossly intact. He does have mild effacement of the right nasolabial fold. His motor examination shows that he has normal tone and bulk. His strength in the right arm and the right leg is 4 out of 5. The left arm and left leg are 5 out of 5 in motor strength. His sensory examination is intact to light touch, temperature, and vibration and proprioception. His gait and coordination are intact, and his reflexes are +2 all over, with a downgoing toe on the left and a Babinski sign on the right. Based on the information you have collected so far, where do you think the lesion is? So based on this animation, do you think the lesion is in the motor cortex? Do you think it's in the corticospinal tracts, along the corona radiata? Do you think it's going to be in the internal capsule? Is it in the brainstem, or is it lower down? And now that you have localized where the lesion is, do you know what is causing the lesion? Remember, there's a mnemonic to remember different etiologies. That's vitamins, which stands for V is for vascular, I is for infectious or inflammatory, T for traumatic or toxic, A for autoimmune, M for metabolic, I for iatrogenic or idiopathic, N for neoplastic. Given the acuity of symptoms, the etiology is probably going to be vascular. Now, which blood vessel do you think was involved? Here is an example of an MRI showing an acute right MCA territory infarct. On the right, you have diffusion-weighted imaging, which would show a stroke as a hyperintense lesion with a hypointense correlate on the ADC map, as shown here on the left. So in our gentleman, the etiology is vascular, and the lesion localization is probably internal capsule. Since it involved face, arm, and leg, it's probably not going to be corona radiata because the fibers are too interspersed to capture all 3 territories, arm, face, and leg together. And it's probably not going to be in the spinal cord or the brainstem because you would expect some other signs, like some cranial nerve findings, some neck pain, some bowel bladder dysfunction, other things like this. Okay, case number 2, 45-year-old Caucasian female with no prior medical problems, presents with, again, right arm and leg weakness. What questions should you ask? So remember, ask about neighboring signs and symptoms that will help you localize. Are there any associated cortical signs, associated brainstem signs, associated spinal cord signs? And ask about the onset of symptoms, whether it was gradual or acute. So the patient says that the symptoms were progressively worsening with right arm and leg weakness over a 2 to 3 week period. She works as an accountant, and initially she noticed that she was having trouble typing with the right hand, which she described as clumsy. A few days later, she noticed that she was tripping on her right side when going for her morning runs. She denies any difficulties with speech. However, she does notice that she has trouble focusing when reading and words run into each other. She denies any neck pain or bowel or bladder dysfunction. Her neurological examination shows that she's alert and oriented ×3. Her speech is intact to comprehension, fluency, naming, repetition, reading and writing. Her cranial nerve exam shows that she has equal pupils reactive to light. She does have an internuclear ophthalmoplegia on the left, and otherwise her cranial nerves are grossly intact. Her motor examination shows normal tone and bulk. She has, like our previous patient, 4 out of 5 strength in the right arm and leg and 5 out of 5 in the left arm and the left leg. Her sensory examination is intact to light touch and temperature. Gait and coordination are intact. Deep tendon reflexes are +2 all over with downgoing toe on the left and again a Babinski sign on the right. Based on the information provided, where do you think the lesion is? So again, remember we have right arm and leg weakness, and we also have internuclear ophthalmoplegia. Do you think the lesion is going to be in the cortex? Do you think it's going to be subcortical? And if subcortical, do you think it's going to be in the corona radiata? Do you think it's going to be in the internal capsule? Or do you think it's going to be somewhere in the brainstem? And now that you have localized your lesion, what do you think is causing your lesion? Remember your mnemonic. Here is a sagittal cut of the brain as well as an axial cut. The axial cut is showing a posterior T2 hyperintensity near the floor of the fourth ventricle. This is what would cause your internuclear ophthalmoplegia, as well as catch the left corticospinal tract as they make their way down, causing right hemiparesis. The sagittal cut shows T2 hyperintensities above the corpus callosum, which is also called Dawson's fingers. This is pretty typical of multiple sclerosis. Case number 3. We have a 50-year-old Caucasian male with no prior medical problems who presents with, again, right arm and leg weakness. So same exercise. What questions should you ask? So neighboring signs and symptoms, and what was the onset of symptoms? Was it gradual or acute? So the patient says that he had acute onset of right arm and leg weakness. He was lifting heavy boxes during a move, and all of a sudden he noticed that he had some right arm and leg weakness. He also admits to associated numbness that's on the left. He denies any difficulties with his speech. He has no diplopia, no vertigo, no dysphagia. He admits to associated neck pain, as well as trouble with holding his urine, which he didn't bring up upon initial questioning. His neurological examination shows that he is alert and oriented ×3. His speech is intact through comprehension and fluency, naming, repetition, and reading and writing. His cranial nerves are grossly intact. His motor examination shows that he has normal tone and bulk. He has 4 out of 5 strength in the right arm and the right leg, and 5 out of 5 strength in the left arm and the left leg. Sensory examination shows that he has decreased sensation to light touch on the right and to temperature on the left, with a sensory level that's around the clavicle. His gait and coordination are intact. His deep tendon reflexes are +2 all over, with a downgoing toe on the left and a Babinski sign on the right. So based on the information you have, where do you think the lesion is? Again, same exercise. Is it cortical? Is it subcortical? What are the neighboring signs you found that helped you localize it? And then what is the lesion? Again, same exercise. Here is the MRI of the cervical spine. Picture A shows a T2 sagittal cut and picture B shows an axial cut. This MRI shows a right herniated disc that's compressing the lateral cord on the right side. And remember, when you have a cord problem, you will have ipsilateral problems, so a right hemiparesis, because the fibers have already crossed. The reason the patient is having left-sided weakness is because left-sided numbness, is because we have what we call a Brown-Séquard syndrome, where you will have crossed signs, weakness on one side and numbness that's on the other side. Final case, case number 4, 5-year-old boy that's born full term, right-handed, previously healthy, reached all his milestones on time, presenting with progressively worsening clumsiness noted when he was trying to eat or play using the right hand. So what questions should you ask? Again, we're going to go through the same exercise. So were there associated cortical or subcortical signs, and what was the onset of the symptoms? His neurological examination shows that he's alert and oriented ×3. His speech is intact to comprehension, fluency, naming, repetition, reading and writing. His cranial nerves are intact. However, he does have multidirectional nystagmus, which is noted on eye movement testing. His motor examination shows normal tone and bulk. 5 out of 5 strength in all extremities, and he does not have any drift. Sensory examination is intact to light, touch, and temperature, vibration, and proprioception. His coordination testing shows that he has dysmetria in the right upper extremity on finger, nose, finger testing. And his gait testing shows that he has right lateral pulsion and mild ataxia. His deep tendon reflexes are intact, his implantar reflexes are intact and downgoing. So where do you think the lesion is, and what is the lesion? And again, you're going to go through the same exercise. This is an axial cut of a brain MRI going through the posterior fossa, showing a right mass that's compressing the right cerebellar peduncle. It represents a medulloblastoma. The resulting deficit would be right arm dysmetria and ataxia, because the cerebellar lesions always cause ipsilateral deficits. We have come to an end to this lecture. I hope you learned a lot. You might need to go through the lecture a few times to assimilate all the content, but I hope you do and repeat the exercises, and I hope that you enjoy it.